I'm Joe Graydon.
And I'm Terry Graydon. Welcome to this podcast of the People's Pharmacy.
You can find previous podcasts and more information on a range of health topics at peoplespharmacy.com. COVID-19 continues to capture headlines, but heart disease is still our number one killer. How can you prevent it? This is the People's Pharmacy with Terry and Joe Graydon.
Most people think that cholesterol is the top risk factor for cardiovascular disease, but lots of other things contribute to your chance of a heart attack.
Have you ever heard of LPA? Do you know what your calcium score is? Why is it so controversial?
When it comes to prevention, most cardiologists agree that diet matters, and the consensus seems to be that a Mediterranean-style diet is a smart way to eat. What does it entail?
Coming up on the People's Pharmacy, find out what you should do to protect your heart.
In the People's Pharmacy Health Headlines, this week, the CDC put out a strong recommendation that people wear masks anytime they ride on airplanes, trains, buses, subways, taxis, or rideshare vehicles. According to the agency, if we all mask up, we can have confidence that we can once again travel more safely, even during this pandemic. Amtrak, airlines, and most public transportation systems already advise or require facial coverings. In fact, U.S. airlines have kept hundreds of passengers off planes because they were not wearing masks.
We now have data showing that wearing masks is effective against transmission of the coronavirus on airplanes. In Hong Kong, officials test every passenger for COVID-19 upon arrival. The travelers are then quarantined in single rooms for 2 weeks and tested again. This has helped Hong Kong control the pandemic in a densely populated city. As a side effect, it tells researchers who flew with an infection before symptoms started to show up and allows them to track others on the same flight. Scientists at the University of Alabama at Birmingham concentrated on passengers of Emirates Airlines because its masking policy is strictly enforced. Between late June and early July, Emirates flew 5 flights from Dubai to Hong Kong with at least 7 infected passengers on them. These 8-hour trips could have been super spreader events, but with the masking policy in force, none of the 1,500 to 2,000 other passengers or crew became infected.
Last week, we reported a JAMA study that indicated 20% more deaths than usual since the pandemic began. Now, the Centers for Disease Control and Prevention have issued their report. According to the CDC, almost 300,000 more people have died between January and early October than would be expected in a normal year. About 200,000 of these deaths are attributed to COVID-19. In other words, 2 out of 3 excess deaths were from COVID-19. Some of the others may have been due to the extreme conditions created by the pandemic. The biggest increases relative to usual times were among young adults, 25 to 44, and people of Hispanic or Latino ethnicity.
Blood pressure is an important risk factor for cardiovascular disease. In recent years, the recommended threshold for treating hypertension has been lowered. Health professionals are expected to help people get their systolic blood pressure below 130 and their diastolic blood pressure readings below 80. But measurement is not as simple as it seems. New research published in JAMA Internal Medicine compared office blood pressure measurements to the careful readings obtained in the SPRINT research trial. There were over 3,000 patients whose data in these 2 different settings were compared. There was surprising variability between the numbers obtained in the office and those in the study. Many of the participants had higher blood pressure readings in the routine office visits compared to the research setting. The range of discrepancy was substantial. A commentary in the same issue of the journal noted that routine blood pressure measurements in the office setting don't often follow established guidelines. The researchers suggest that improper blood pressure measurement technique might have contributed to the problem.
There's a reason your grandmother told you to eat your vegetables. Vegetables and fruits are good sources of flavonols, plant compounds that appear to have health benefits. A large epidemiologic study just confirmed that people who have higher levels of flavon-3-ols in their urine also have modestly lower blood pressure. These compounds are found in foods like berries, cocoa, tea, apples, and nuts. The research was published in Scientific Reports and included more than 25,000 participants. Men who had high levels of urinary flavon-3-ols had systolic blood pressure almost 2 points lower on average. For women, the difference was about 2.5 points. The investigators point out that even a small reduction in systolic blood pressure is associated with lower mortality rates. They conclude flavonol intake could therefore have a role in the maintenance of cardiovascular health on a population scale. And that's the health news from the People's Pharmacy this week. Welcome to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. COVID-19 has captured everyone's attention, and rightly so. It's now the number 3 killer in the United States, but heart disease is still number 1. Today, we're talking about ways to identify people at risk and how they can prevent heart disease.
Our guest is Dr. Michael Blaha. He's professor of cardiology and epidemiology at Johns Hopkins. He's the director of clinical research for the Johns Hopkins Ciccarone Center for the Prevention of Cardiovascular Disease. Dr. Blaha practices as a preventive cardiologist and in the interpretation of cardiac CT. He's an associate editor for the journals Atherosclerosis and the Journal of Cardiovascular Computed Tomography. Dr. Blaha serves on an advisory committee for the Food and Drug Administration. Welcome to the People's Pharmacy, Dr. Michael Blaha.
Yeah, my pleasure being with you today.
Well, thank you for joining us. Dr. Blaha, your main focus is preventive cardiology. What does a preventive cardiologist do to prevent our still number 1 killer?
It's a great question. What is a preventative cardiologist? And I would argue that a preventative cardiologist has a very different outlook than for example, interventional cardiologist. Whereas an interventional cardiologist might work at opening arteries of ones that are blocked, abating heart attacks, or fixing rhythm abnormalities in the heart. A preventative cardiologist really thinks more upstream of those diseases and thinks about the risk factors and preventing those diseases in the first place. So preventive cardiologists usually have a mindset that's much more aimed at sustainable healthcare, early intervention, lifestyle intervention to try to prevent diseases from happening in the first place. So really combines elements of public health, lifestyle, and cardiology, and frankly, some primary care into the framework of a cardiologist practice. So anyway, that's what attracted me to preventive cardiology.
Now, Dr. Blaha, you are also an expert in heart imaging, which I think not all preventive cardiologists are. Can you tell us what sorts of images you use? How is it done? And what does it tell you?
That's another great question. So this speaks a little bit to the evolution of the field of preventive cardiology. Once upon a time, preventive cardiology was basically synonymous with lipidology, treating cholesterol in the bloodstream, because it was a relatively simple proposition to think that cholesterol equals plaque in the arteries. Of course, now we recognize that it's really an order of magnitude more complicated than just cholesterol. It's type of cholesterol, but also blood pressure, blood sugar, genetics, other factors that we're discovering now. So really, it's no longer lipidology, it's atherosclerosisology, if you might. That's trying to measure and quantify and predict the burden of plaque in the arteries. So what happened over time is preventive cardiologists thought more broadly than just about cholesterol. They thought about the vessel wall. It was important for a preventive cardiologist also to have tools to image the degree of early disease in the vessel wall. not just, for example, measure blood cholesterol on a blood test. So what preventative cardiologists really have moved into is the field of cardiac CT, computed tomography. CT allows us to see early plaque within the vessel wall, either as a form of either calcium deposition within the wall or on a CT angiogram, actual early plaques within the vessel wall. So this has become an important tool of the preventive cardiologist to take a patient who might be at risk, but early, measure how much disease there is in the arteries and try to, from a precision medicine point of view, titrate how aggressive you are with therapies to how much disease there actually is in the blood vessels. So most preventive cardiologists in training right now are also atherosclerosis imagers.
Dr. Blaha, I remember several years ago, one of my tennis partners had, I don't recall what it was that triggered this, but he had something that got him in to see a cardiologist, and he did a stress test, and the results were a little bit unclear. There was some ambiguity there. And then he was to undergo a CT scan, the kind of thing that you're talking about. Now, this guy played tennis 3 or 4 times a week. He usually ran about 5 or 10 miles a week, sometimes 20. He was thin. His blood pressure was great. He was in phenomenal shape. But he got really worried. And then the CT scan results came back, and it was like clean as a whistle. And it was like, whew, I'm all clear. That was great. I got a diagnostic test that revealed that my coronary arteries are just fine. I don't need to take a statin. I don't need to do anything other than keep doing what I'm doing. So in his case, your kind of test was a great boon because it eased his mind and he didn't require any, serious interventions. But I have to tell you, the CT scan is still somewhat controversial, and we have talked to Dr. Steve Nissen, another cardiologist who I suspect you are familiar with, and he basically said, that calcium score, it's not as great as they say, especially if someone's been taking statins. Can you tell us why that might be?
We bring up a couple great points there with that anecdote. The first thing I'll say is that your story there reflects really the change in thinking that we're having in cardiology. So in the past, it might have been the case, that you knew someone who went into a cardiologist's office and was relatively free of any symptoms, and lo and behold, ended up with a stress test. So this is outdated thinking now. We aren't going to be doing stress tests in people who don't have symptoms anymore, going to look for something that we don't suspect is there. We recognize now this can lead to a cascade of tests and thinking about a patient when they ultimately are doing quite well. So the new thinking in cardiology is that we're not going to go looking for what we call ischemia, lack of blood flow to the heart muscle, before we even know if a patient has any disease or not. So that would be my first remark about the example you gave, which fits very nicely into the preventative cardiologist paradigm, which is we're not going to be going to look for lack of blood flow to the heart muscle before even starting with the basics of risk factor management and assessment for plaque burden. The next thing you brought up is the idea of the CT scan. Now, there's 2 different kinds of CT scans. There's the simple kind where you look for calcium. That generally is for asymptomatic patients. And then there's the kind where you use contrast and you actually do a CT angiogram that looks like a cardiac catheterization. That's the test that you probably mentioned there in the anecdote. And that really is there for people who have symptoms. So getting back to the test that we do on patients who don't have any symptoms, that's the calcium score. And we do that when indicated to try to look for how much plaque there is in the arteries and decide where someone is in the natural history of plaque development and how to treat them. Now, there's some naysayers out there, clearly, but the good thing is the guidelines are clearly endorsing kind of this new paradigm. The new ACC/AHA guidelines give a class 2A recommendation to doing a calcium score if you're so-called borderline to intermediate risk and are uncertain about taking preventive therapies or how aggressive to be. Dr. Nissen is a good friend of mine. We've talked about this many a time, and I think he would agree that the calcium score is a great test for risk prediction in people who kind of haven't undergone treatment yet, early in the consideration of risk. But later in the disease process, when maybe a patient has symptoms or a patient has been treated a very long time, the calcium score no longer becomes as favorable a test because where we usually use it is to decide how aggressive to be in preventative therapy. But once a patient has been in, say, a cardiologist practice for many years and is now considering their symptoms, for example, maybe do they need a stress test? That's where the calcium score no longer plays as much of a role. So I think we're learning where to use the test. And that's where kind of Dr. Nissen and I's worlds would come together in kind of agreement on that there's a time and a place for the test, but we got to make sure it's used appropriately.
Well, tell us a little bit about when it would be used appropriately. You suggested that it's a great test when indicated. When is it indicated?
So I would give two broad indications for the calcium score, and these are straight out of the guidelines. So these are consensus international guidelines, not just my personal opinion. The first instance is, like I mentioned, a patient with so-called borderline to intermediate risk. What do I mean by that? I mean a patient who's not clearly low risk, patient who's not young with no risk factors, for example, and not a patient who's clearly high risk. This would be a patient with 4, 5 cardiovascular risk factors. People in between are patients what we call intermediate. They have some risk factors, but they're not overwhelmingly high risk. And we know that a certain amount of these patients will develop heart disease in their lifetime. This is where the guidelines give a favorable class 2A recommendation to do what's called a calcium score, the simple non-contrast 5-minute CT scan to see if they have a lot of plaque in their arteries. And it can help decide whether they need to be treated more aggressively, but also, as you mentioned, very importantly, determine which patients are actually lower risk than you thought and need to be treated less aggressively. So you can have patients that come out of the other end of a calcium score being treated both more aggressively or less aggressively. So that's nice. They can actually find patients who are truly lower risk than you thought too. The other indication would be a patient who might not yet be at the borderline to intermediate risk group, might be at the low to borderline risk group, but has a very strong family history or another, what we call risk enhancing factor that's not accounted for in traditional guidelines. This might also be, for example, a very high lipoprotein A test because of a family inheritance. These patients who we know are potentially at high risk, for example, the SCCT, the Society of Cardiovascular CT, supports considering a calcium score in a patient who might be a little lower on the risk spectrum, but has a very strong family history, who wants to figure out early in life if they need to be treated aggressively. That's another place to use a calcium score. So once again, intermediate risk patients, lower risk patients, they're borderline risk patients with strong family history. I think that's two groups that we can mostly all agree on.
You're listening to Dr. Michael Blaha. He's professor of cardiology and epidemiology and director of clinical research for the Johns Hopkins Ciccarone Center for the Prevention of Cardiovascular Disease. Dr. Blaha practices as a preventive cardiologist and in the interpretation of cardiac CT.
After the break, we'll learn more about calcium. Are calcium supplements a problem for the heart?
You'll also find out more about a little-known risk factor called Lp(a).
What other heart disease risk factors should you monitor? What about a family history of heart disease?
You can also get answers to a question about statins. Who benefits most?
Do doctors have any way to help patients trying to deal with stress and hostility? Those are heart disease risk factors, too.
You're listening to The People's Pharmacy with Joe and Terry Graydon. The People's Pharmacy podcast is supported in part by CocoVia Memory Plus. CocoVia cocoflavanols support both cardiovascular health and cognitive function by promoting healthy blood flow, transporting oxygen and nutrients to vital organs and muscles, including your heart and brain.
CocoVia Memory Plus has 750 milligrams of cocoflavanols, the plant-based nutrients from fresh cocoa that have been proven to help boost memory.
CocoVia Memory Plus is backed by 4 clinical trials that demonstrate improvement in 3 different aspects of memory: long-term memory, spatial memory, and word recall. The studies show improved brain function in just 8 weeks.
You can try the benefits of CocoVia Memory Plus with a 25% discount off your first month. Use the code PEOPLES25. To get the full benefits, take it daily for 8 weeks. CocoVia is offering People's Pharmacy podcast listeners a 10% discount on subscriptions. That code is Peoples10. Learn more at cocovia.com. Welcome back to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon.
The People's Pharmacy is brought to you in part by CocoVia Memory Plus, a cocoflavanol supplement backed by 4 clinical studies that show significant improvement in 3 different aspects of memory. More information at cocovia.com.
Also by Verizana, an analytical laboratory providing home health tests for hormones, gut health, and the microbiome. Online at verisana.com.
Have you ever been tested for cholesterol? Most people have. The blood test usually involves total cholesterol, so-called bad LDL cholesterol, and good HDL cholesterol. What about something called Lp(a)? Why is this lipoprotein important for some people? And what about calcium? The plaque that builds up in coronary arteries is mostly made out of calcium.
Our guest is Dr. Michael Blaha, professor of cardiology and epidemiology at Johns Hopkins. He's the director of clinical research for the Johns Hopkins Ciccarone Center for the Prevention of Cardiovascular Disease. Dr. Blaha practices as a preventive cardiologist and in the interpretation of cardiac CT. He's an associate editor for the journals Atherosclerosis and the Journal of Cardiovascular Computed Tomography. Dr. Blaha serves on an advisory committee for the Food and Drug Administration.
Dr. Blaha, calcium. When people think about plaque, the stuff that clogs their arteries, they may not think about calcium. Calcium is like chalk, calcium carbonate. Now, I'm curious about all of those calcium supplements that people have been taking, especially women, to build their bones stronger. We've read about some research recently that when people take a lot of calcium in the form of pills, that it may actually cause calcification of soft tissue, perhaps even in heart arteries. Any thoughts about that? And should people be a little more careful about calcium?
Well, generally speaking, I think these are actually 2 separate things. Generally speaking, calcium in the arteries is indicative of plaque development. And it's really, we use calcium as just a marker on a CT scan of plaque, but it's really not what we're most focused on. So I personally don't see a strong correlation between, for example, your calcium level or dietary calcium and calcium in your blood vessels. They're really separate concepts. But you do raise an interesting question of whether there is strong evidence for taking high doses of calcium supplements. And I don't think there is great evidence for that. And there is some evidence that there could be unfavorable effects on the cardiovascular system via a variety of mechanisms, but including potentially calcification of the arteries. So generally speaking, calcium in the arteries does not equal dietary calcium, but it's a legitimate question whether we should be recommending strong, high doses of dietary calcium at all.
Now, you mentioned something called Lp(a). People refer to it as lipoprotein A or Lp(a). And for the last 30 years, I think most healthcare professionals have focused on something else called LDL cholesterol. That was kind of the bad guy. LDL cholesterol was, the stuff that caused plaque in coronary arteries, and statins were perceived as the hammer for that nail. So I'm wondering about other risk factors for heart disease besides LDL cholesterol, which does come down beautifully with statins, but sometimes statins can raise Lp(a). And so it's sort of like driving with your foot on the gas and the brake at the same time. Tell us a little bit more about Lp(a) and other risk factors for heart disease.
Well, you hit on a very important concept, which in a prior interview, I think I mentioned the same thing, which is that atherosclerosis should be considered very multifactorial. And it's not just about your cholesterol. Cholesterol is just one risk factor. LDL cholesterol is just one risk factor in the midst of diabetes and lifestyle factors, et cetera. And even within cholesterol, where there's now a order of magnitude more complexity that we understand than we used to. Once was total cholesterol, then it was bad and good cholesterol. Now we're even breaking the bad cholesterol down into into what the size of those particles, how many particles that you have, what the protein component of those particles is. And also there's a subfraction of your LDL cholesterol called the so-called lipoprotein A. It shows up on your blood panel as part of the LDL cholesterol, but it's actually its own specific thing, largely inherited. Some patients can have extremely high levels, while certain patients can have extremely low levels. And this is quite variable across populations and races. And it turns out the lipoprotein A molecule is highly atherogenic. It can lead to atherosclerosis in people who have very high values. So it's important to know in many patients what your level is. Now, we don't have a therapy for it yet. We still just recommend statins, but there are therapies coming in the pipeline in testing right now for lipoprotein A. So this, in the next couple of years, might be a brand new way of intervening on atherosclerosis risk. And right now, we're just measuring Lp(a) in patients with strong family histories, in patients who have premature disease, et cetera.
Well, this kind of explains why I've heard of cases where someone says, strong family history of heart disease. Dad died of a heart attack when he was in his 50s. Mom had a heart attack in her 60s. I've been taking statins for 20 years, and now they tell me my coronary arteries are clogged and I might need a stent. Maybe they have high Lp(a) and didn't even know it.
That's right. That would be a reason we would measure Lp(a). Absolutely. That's the strong family history, especially when the inheritance pattern of that family history is not fully explained by other risk factors. For example, if you have a strong family history and your LDL cholesterol is 300, you have what's called familial hypercholesterolemia, and that's likely the explanation. But many patients with family history don't really have clear traditional risk factors for heart disease. You need to look further. And besides other genetic factors, one of the most prominent risk factors is definitely this lipoprotein A value. And I'm routinely checking it in all my patients with strong family histories. Now, the problem with it is that you measure it and you can't really lower it just yet. But hey, there's therapies that will be here very soon for this. And it's still important to know if my patient has high Lp(a), I will lower their LDL cholesterol even further to kind of make up for the risk that comes from that inheritance.
Dr. Blaha, I would like to ask about statins because people are very familiar with these drugs to lower cholesterol. You have suggested elsewhere that they're really helpful for people who may benefit, but not everyone benefits. How will we know who is going to benefit and who doesn't?
This is a great question. I mean, the academic debate runs from everything from treat every single person at a young age, to treat only those patients who've had a heart attack before, which might differ from 300 million people taking the drug to only a couple million. So really the thinking on the topic is varied. Guidelines come down on the general concept that you have to be of sufficiently high risk if you haven't had a heart attack before to get a benefit from statins. And I generally agree with that. I think we can find patients that are more likely to benefit. We don't necessarily need to treat everyone. So the question is, how do you find who's going to benefit? Well, you clearly need to treat patients with so-called familial hypercholesterolemia, whose LDL cholesterol is just sky high from birth. Generally speaking, we need to treat patients who have very severe diabetes, regardless of their cholesterol values. And beyond that, I think what we can do is look at a totality of the risk factors, and then in many cases, actually measure the plaque directly with a CT scan. And if there's substantial plaque in the arteries, they need to be on a statin. The statin can help modulate that plaque and help regress that plaque, actually. But if there's no plaque in the arteries whatsoever, and there's no major outstanding cholesterol-related risk factors, many of those patients, I think, can get it by with lifestyle alone rather than pharmacologic treatment. So I think we just need to be smarter and more precise on who we give statins to. I'm not necessarily saying we're overusing them, and I'm not even saying we're underusing them. I just think we need to be more thoughtful and precise about who we use them in, and I think we have the tools to do that.
Dr. Blaha, I'm curious about risk factors because you've mentioned that a number of times. And I think a lot of times people focus on total cholesterol, LDL cholesterol. They may focus on blood sugar and blood pressure, but there are other factors that may also play an important role, things like hostility. things like inflammation, CRP levels. A sedentary lifestyle can be a risk factor. People with insomnia, people under stress. How do you, in your practice of preventive cardiology, go through all of the risk factors, not the least of which is diet, and help people make the changes that could make a really big difference? I'm thinking now back to the Anger Kills book that was popular maybe 20 years ago by Dr. Redford Williams at Duke University. How do you help people with things like hostility and stress?
That's a great question. But I think the larger point you're making, which is that the preventative cardiologist is really someone who looks at the totality of risk factors for an individual. If you're ever seeing your busy interventional cardiologist, they really don't have time to talk about all of these other issues, even if they recognize they're important. But it's incumbent upon the preventative cardiologist to look at the totality of risk for an individual and figure out where best to intervene. So you're right. There's so many risk factors. There's things that we measure in the bloodstream. There's things we measure, for example, from a blood pressure measurement. And then, of course, the preventive cardiologist has to talk to the patient and figure out what is the driving risk in that person's scenario. It very well could be stress. It could be work stress or emotional stress. It could be reflected in sleep or lack of physical activity or eating habits. All of those things, while sounding like a very long list, are actually very related, right? We all know that people that are overworked, overstressed, without healthy relationships, sleep less, eat less well, exercise less effectively, et cetera. So we try to talk about those as kind of all one and the same thing. And most preventive cardiology practice will also be armed with nurses, nurse practitioners, or other clinicians who are expert in thinking about lifestyle. So I'll talk to my patient about this. My team will talk to the patient about this, maybe in a separate visit or after my visit. We'll just try to figure out for that particular patient what's driving their risk. And I recognize that not all of these are easy to change, but we were pretty effective, I think, in at least alerting patients to how their lifestyle affects their health. And you're right that all of those things are important and are legitimate risk factors. And if we're only focusing on what we can measure in the bloodstream, we're going to miss a lot of the risk that we see across the population in America.
Now, Dr. Blaha, our listeners are very interested in your recommendations for how they can keep their hearts healthy. So what do you suggest for diet, for exercise, for stress management at this point?
Yeah, the good thing is it's in some ways it sounds very complicated, but in other ways it's just extremely simple. It's been shown that if you have at least a moderately healthy diet, you exercise most days of the week, at least 30 minutes, you get reasonable amounts of sleep that can vary by the individual, your blood pressure is normal, your cholesterol is at goal, you don't have diabetes and you're a normal weight, that your risk of cardiovascular disease is just tremendously low compared to the average person. These are just basic things. In fact, the American Heart Association has something called the Life Simple 7. It's simple because it's just those things that I mentioned: diet, exercise, weight, blood pressure, things like that. If all of those are in the optimal range, which is where we start out in life, your risk is extremely low. So really, it's just about maintaining the health that we're given at a young age into adulthood and not letting that slip. So, while we spend a lot of time talking about predicting risk, it actually is pretty simple when you come down to it, just maintaining those things we know about. If you can maintain all those things at a healthy levels, your risk is pretty low. So what I recommend is, while your listeners should be aware of things like Lp(a) and other things, that they shouldn't lose sight of the basic things, which is just eat healthy, exercise most days of the week, be aware of your blood pressure, make sure your cholesterol isn't too high, maintain a healthy weight. Your risk will be very low.
It sounds simple, but maintaining a healthy weight can be challenging, especially in these times of COVID-19 where people are home snacking away. And so losing weight, boy, that's hard. And what is a healthy diet? I mean, there are people out there who say more carbs, more protein, less protein. Oh, you don't have to worry about Saturated fat, it doesn't cause heart disease. Look at all these studies that show no correlation. And other people say, oh, no. Saturated fat is absolutely the enemy of heart disease. And so trying to figure out what's a healthy diet is not always so easy.
Yeah, I think what you're hitting on is an important point, which is that there's no one diet. We're omnivores. We can eat a variety of things, and there's probably a lot of healthy diets out there, but we can establish some general patterns that are unhealthy. It's most helpful if you don't think about particular macronutrients only. For example, only think about carbohydrates or only think about saturated fat, and think about the totality of the diet. And if the totality of the diet is rich in fresh things and non-processed foods and fruits and vegetables and non-processed grains and whole wheats, fiber-rich foods, you can achieve that diet a variety of different ways. We like recommending a so-called Mediterranean type diet because it's very palatable, a lot of fish and fresh fruits and vegetables and complex carbohydrates. But there's other ways of doing it too. So I think that's the message I have, is when someone comes to me and says, what's the right diet? I step back and say, I want to talk about healthy eating patterns in general. Not eating too often, eating healthy reasonable portion sizes, and eating, generally speaking, fresh foods that have names and not just macronutrients, then you're going to be well off. So I think we do a disservice by choosing the one diet that works or talking about only one macronutrient or one food. You need to eat more of this food and missing the big picture. So that's my opinion on that. And I think fads in diet come and go. We all know that. And it's all about general healthy patterns. And we actually do have pretty high quality evidence on at least that. Once again, if you reduce your processed food intake, more fresh foods, that includes fruits and vegetables and things with lean proteins and healthy oils like oily fish, like salmon and other lean meats, you're generally speaking eating a healthy diet.
Dr. Michael Blaha, thank you so much for talking with us on the People's Pharmacy today.
Yeah, my pleasure. Thanks for having me on.
You've been listening to Dr. Michael Blaha, Professor of Cardiology and Epidemiology at Johns Hopkins School of Medicine. He's the Director of Clinical Research for the Johns Hopkins Ciccarone Center for the Prevention of Cardiovascular Disease. Dr. Blaha practices as a preventive cardiologist and in the interpretation of cardiac CT. He has received multiple grant awards from the National Institutes of Health, FDA, American Heart Association, Amgen Foundation, and the Aetna Foundation.
Any decisions about medications, including statins, should be made in collaboration with your doctor. No one should ever stop any medicine without consulting the prescriber.
Dr. Blaha is not the first cardiologist to mention the Mediterranean diet as desirable. But the bottom line from most People's Pharmacy experts is that we should be eating more vegetables and fruits and as little processed food as possible. If you can't pronounce the chemicals on your food package, that's a tip you should probably put it back on the shelf.
After the break, we'll turn to an expert in blood fats like cholesterol.
How important is LDL cholesterol?
How much does diet affect your cholesterol levels, and how much does that affect your risk of heart disease?
What factors are most important in determining your chance of a heart problem?
We'll talk about statin drugs, healthy diets, and lifestyle.
You're listening to The People's Pharmacy with Joe and Terry Graydon.
This People's Pharmacy podcast is brought to you in part by Verisana.com.
Verisana Lab offers home health tests that allow you to monitor your hormones and health conditions. You can take control of the quantitative assessment of your health and learn about male and female hormone balance, the stress hormone cortisol, leaky gut, gluten intolerance, or your gut microbiome.
Take a more active role in tracking your health and take 20% off your first order of a mail-in testing opportunity with the discount code PEOPLE. That's uppercase PEOPLE. To learn more, go to Verisana.com. That's VERISANA.com.
Welcome back to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon.
The People's Pharmacy is brought to you in part by CocoVia Memory Plus, a supplement with 750 milligrams of cocoa flavanols, the plant-based nutrients from fresh cocoa that help support memory. More information at cocovia.com.
Also by Verisana, an analytical laboratory providing home health tests for hormones, gut health, and the microbiome. Online at VERISANA.com.
Today we're talking about how you can protect your heart. We've talked about a range of risk factors. Now we're going to focus more specifically on LDL cholesterol and other lipoproteins.
We're talking with Dr. Robert Dubroff. He's a clinical professor of medicine in the Division of Cardiology at the University of New Mexico School of Medicine in Albuquerque.
Welcome back to the People's Pharmacy. Dr. Robert Dubroff.
Thank you very much for the invitation. Glad to be here.
It's nice to have you back on the People's Pharmacy, Dr. Dubroff. And I think our listeners would like to know a little bit about you. You are a lipidologist, and I think that's not something the average patient would run into. They go to see their primary care doctor, maybe even their cardiologist or their internist, but they may not realize that there's also this field called lipidology. Could you explain what it does and why it's important?
Certainly. I started my career as a cardiologist, but I became concerned that I didn't fully understand cholesterol and how it relates to causing heart disease. So I undertook a small fellowship at the University of California, Berkeley, specifically to learn more about this. And then there now is a certification exam that one can take to become a certified lipidologist. So I did that as well. So I ended up specializing in cardiovascular prevention with some expertise in lipid disorders. And I tend to see a lot of patients refer to me for prevention of heart disease, high cholesterol or triglycerides or other metabolic abnormalities that may be related to the development of heart disease.
Well, heart disease is important. It's still our number one killer. And of course, in this time of COVID-19, it's one of the important comorbidities that make severe COVID-19 complications more likely. So when we talk about heart disease, what we hear a lot is LDL cholesterol, you've got to get it down. And statins are the major solution. Is that reasonable?
Well, that has been the recommendation for several decades. And there is a lot of evidence to support that approach. But I would say that not all the evidence is convincing. And in fact, I've undertaken a number of investigations looking at the literature, looking at the randomized controlled trials of using statins and other agents to lower LDL cholesterol, to see if they always result in a beneficial effect in terms of preventing heart disease or reducing mortality rates. And my research actually disclosed that there are, in fact, many studies using statins and other agents to lower cholesterol that did not report a clinical benefit. So I think much of the evidence is inconclusive or certainly not persuasive to me.
Well, Dr. Dubroff, you have actually written a couple of articles recently in a journal called BMJ Evidence-Based Medicine, and your co-authors have been cardiologists. So you're not outliers. You're not on the fringes of medicine. You're right in the mainstream of the field. One of your articles was Fat or Fiction, the Diet Heart Hypothesis. And then more recently, Hit or Miss, the new cholesterol targets. You have really aggravated a lot of your cardiology colleagues. Perhaps you could go into a little more detail about what you discovered in these two publications.
Sure. Let's start with fat or fiction. I think I've felt for many, many years that you needed to lower your intake of fat, especially saturated fat, in order to prevent heart disease. And that was basically what I told patients for many, many years. But as I started to look into this in more detail, I realized that, in fact, there were quite a few trials that had been conducted, randomized controlled trials, where the experimental group was put on a low-fat diet versus a control group, which was allowed to eat their regular diet. And what I found, surprisingly, is very few, if any, reported clinical benefit. So I did a systematic review of every dietary trial I could find that met certain criteria to look at the outcomes of a low-fat diet. And what I found is very few actually reported a benefit. And in fact, only 2 dietary trials reported an improvement in longevity or a reduction in mortality. And those 2 trials, interestingly enough, did not lower cholesterol levels at all. One of them involved a Mediterranean diet, and the other simply involved adding fish to the diet. So I think sort of the takeaway message from my research was that reducing saturated fat in your diet and or specifically replacing it with unsaturated fat in the diet does not produce a consistent benefit in the studies that we reviewed. Now, getting back to the other publication, which was in the British Medical Journal, Evidence-Based Medicine, on cholesterol targets, for many, many years, physicians and clinicians have been advised to lower cholesterol to certain target levels in order to prevent cardiovascular disease. And so what I did was, again, a systematic review of every trial we could identify, randomized controlled trial, that looked at lowering cholesterol using the 3 drugs that are currently recommended by the American Heart Association and the American College of Cardiology. And what we found is that if the targets were met, some of the studies reported a benefit, but if the target was not met, some of the studies reported benefit. In fact, a higher frequency of the studies reported benefit compared to the studies that did actually meet the target. So the question that we have to ask after looking at all this evidence is it really worthwhile to achieve those targets? We're not saying statins don't work. We're just saying if we use LDL targets as a surrogate for treatment goals, does it really achieve the benefit we're expecting? And part of that discussion looks at different population studies. For example, in some of the European countries, they've looked at the use of statins, which have exploded. Serum cholesterol levels have dropped, and yet the incidence of cardiovascular disease appears to be essentially unchanged. And similarly, in the United States, if you look at the statistics, statin use has almost doubled in the last decade or so. Serum cholesterol levels are dropping, and yet we still have extremely high levels of cardiovascular disease. And in fact, by some reports, it's going up rather than going down. So there seems to be a disconnect here between widespread use of statins, lowering cholesterol, and yet at a population level, cardiovascular disease doesn't seem to be going away.
I don't have to tell you, but I will mention to our listeners that your ideas have roused quite a lot of controversy among your colleagues. Why do cardiologists find it so disturbing to have someone challenge the diet heart hypothesis, as it were, or the cholesterol hypothesis?
Well, obviously, I can't speak for others, but my sense is that this concept of lowering cholesterol, reducing saturated fat in your diet, is so ingrained, and people have established their careers on this basis, that it is challenging to deal with evidence that seems to contradict that. There's a behavior called confirmation bias, which refers to the fact that as humans, sometimes we tend to focus on information or evidence that supports our opinion, but we tend to ignore evidence that might contradict it. And this has happened throughout the history of science, not just in this particular area regarding cholesterol. And I think much of this reluctance is simply an acknowledgement that, wait a second, how could we be wrong after all these years? we've been focusing almost exclusively on lowering LDL cholesterol. This impacts millions of people worldwide. To acknowledge that it might be somehow misguided is a major upsetting event.
Well, what I find so fascinating is that over the last decade or two, we have seen statin prescriptions, as you say, just explode. And I think at last count, 40 million Americans are taking a statin. You would think that with that degree of penetration, there would be a dramatic drop. I mean, like 50% less cardiovascular disease. Heart disease should no longer be the number one killer. It should be like number 5, number 10. It should have been reduced just dramatically. And you're suggesting that we haven't seen that.
That's exactly right. And in fact, enthusiasm for statins is very widespread. And there was an editorial published in Science many years ago by some Nobel laureates who said that with the advent of statins and new evidence of their effectiveness, we may well see eradication of cardiovascular disease within the next decade or two. And it just hasn't happened. Statins are being used, widespread, and yet the population evidence doesn't seem to indicate that we're seeing the benefit that a lot of people expected. It brings up a couple other issues. The first is sometimes when a randomized controlled trial is released or published, they often cite the results as something called relative risk.
Mm-hmm.
And this can be a bit misleading because a more accurate conclusion has to do with absolute risk. And although it varies from study to study, one could, for example, have an absolute risk reduction of maybe 1%, but a relative risk reduction of 30%, just as hypothetical examples. And of course, the pharmaceutical industry would be much more likely to say there was a 30% reduction in risk versus a 1% reduction in risk. But in fact, if you look at the patient level, talking to patients about the absolute risk and the number of patients who would need to be treated to prevent one heart attack, it gives a completely different read on the benefit compared to talking about relative risk. So I think that's one issue that's been largely ignored. Another one is the whole concept of adjusting treatment according to the perceived risk of the patient. In other words, the general approach has been the higher the risk, the more intensive we need to treat. And intuitively, it makes sense, but unfortunately, the evidence doesn't really support that. And let me give you a couple examples. The goal of these guidelines, broadly speaking, is you want to prevent cardiovascular disease in those at highest risk, and you want to avoid treatment in patients who are at low risk and really don't need to be treated. So relative to the first issue, there have been 2 studies recently published that looked at relatively young patients who came in with a myocardial infarction. These are clearly patients that if you could have prevented a heart attack, you would want to do so. But when the authors of these studies went back and calculated their risk to see if these patients would have been candidates for statins, they found that the majority of them would not have qualified for statin therapy. In other words, our traditional means of assessing risk failed to identify these young people who went on to have heart attacks. Conversely, in a study called MESA, they did coronary artery calcium scans. This is a CT scan of the heart, and it measures calcium in the coronary arteries, which has been shown to be a very good predictor of future cardiovascular disease. And what they found in their population was that if they calculated their risk using the equations recommended by the American Heart Association, the patients should be placed on a statin. But when they did the coronary artery calcium score, they had 0 coronary artery calcium, meaning their risk was very low. So we have this contradiction. We have a calculated risk saying treat the patient, but we have evidence of absence of disease saying these people are at low risk and don't need to be treated. So the point I'm trying to make is we need to rethink this approach of using risk in general to assess the need for treatment and the intensity of treatment.
Well, Dr. Dubroff, what risk factors actually do matter? Sometimes I worry that people may start taking a statin and say, okay, I'm taking a statin. I don't need to pay attention to my diet. I don't need to worry about exercise. I'm good.
Well, I think the first point is it's important to distinguish between a risk factor and a causative factor. A risk factor is something that can be associated with a higher risk of developing disease. That doesn't necessarily mean that if you treat the risk factor, you prevent the disease. And you're right, there are many patients who take a statin drug, they lower their cholesterol, and they get a sense of security that we're now protected. But in fact, that isn't the case. I'm not sure we'll ever have clinical trials that will compare one treatment versus another in the sense of looking at the benefits of lifestyle changes versus taking a statin drug. But from everything I've read, lifestyle changes are still the most important preventive strategy. And by lifestyle change, I'm referring to eating a healthy diet, specifically, I think, a Mediterranean-type diet, not smoking, keeping your body weight at ideal levels, and some form of regular exercise. Studies that have looked at individuals who follow those sorts of lifestyle behaviors are much, much, much less likely to develop cardiovascular disease.
Dr. Robert Dubroff, thank you so much for talking with us on the People's Pharmacy today.
You're very welcome.
You've been listening to Dr. Robert Dubroff. He's a clinical professor of medicine in the Division of Cardiology at the University of New Mexico School of Medicine in Albuquerque. You can find a link to the abstract of his article, Fat or Fiction, the Diet Heart Hypothesis, on our website, peoplespharmacy.com.
Both of our guests today agree that you should discuss your own risk factors with a healthcare provider who knows you best to learn how you can protect your heart.
Summing up the recommendations of our two cardiologists, lifestyle matters. It makes sense to maintain a healthy weight. Follow a Mediterranean-style diet rich in fruits, vegetables, fish, and olive oil. Exercise regularly, and don't smoke. And next time your doctor recommends a medication, ask about absolute risk reduction as compared to relative risk. That way, you can make an informed decision together.
Lynn Siegel produced today's show. Al Wodarski engineered. Dave Graydon edits our interviews. B.J. Liederman composed our theme music.
The People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC.
The People's Pharmacy is brought to you in part by Verazana, an analytical laboratory providing home health tests for hormones, gut health, and the microbiome. Online at verisana.com.
And by CocoVia Memory Plus, a cocoflavanol supplement backed by 4 clinical studies that show significant improvement in 3 different aspects of memory. More information at cocovia.com.
To buy a CD of today's show or any other People's Pharmacy episode, you can call 800-732-2334. Today's show is number 1232. The number again, 800-732-2334, online at peoplespharmacy.com.
When you visit our website, you can share your thoughts about today's show. You could subscribe to our podcast through Apple, Stitcher, Google, or your favorite podcast provider. It's posted on our website every Monday morning.
At our website, you can sign up for our free online newsletter to get the latest news about COVID-19 and other important health stories. In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thank you for listening. Please do join us again next week. Thank you for listening to the People's Pharmacy Podcast. It's an honor and a pleasure to bring you our award-winning program week in and week out. But producing and distributing this show as a free podcast takes time and costs money.
If you like what we do, and you'd like to help us continue to produce high-quality, independent healthcare journalism, please consider chipping in.
All you have to do is go to peoplespharmacy.com/donate.
Whether it's just one time or a monthly donation, you can be part of the team that makes this show possible. Thank you for your continued loyalty and support. We couldn't make our show without you.